small branch retinal vein occlusion here, which is not seen in a, which is not seen in the blue reflectance image. The vascular details are more markedly seen in a green reflectance image. The red reflectance image shows more details of the choroidal vessels and the RPE. So this is the multicolor imaging of an epiretinal membrane. This is the reflectance image. So in an ERM, this helps in better identification of the global area of involvement and also helps us in identifying the edge so that you can have a preoperative planning on where to start the peeling. Multicolor imaging helps us in better identification of macular edema, especially diabetic macular edema. The blue reflectance image shows areas of cotton wool spots very clearly. The hard exudates are seen with much more precision. So are the microaneurysms and hemorrhages, which are more clearly seen in the green reflectance imaging. The red reflectance imaging again shows the retinal pigment epithelial and choroidal details. In a proliferative diabetic retinopathy, multicolor imaging gives you a better identification of the neovascularization and surrounding traction. In a dry AMD, we know reticular pseudotrusins are predecessors for a neovascular growth. So we need to identify them, and a multicolor imaging picks up these lesions much better than a conventional photography. You can see the target-like lesions in the multicolor imaging. Drusins are better made out. The margins are well defined. For following up a case of dry AMD, multimodal imaging is of good value. So this multicolor shows an area of non-exudative CNVM, which the OCT angio really picks up. So you might get some clues by looking at the multicolor imaging to presence of a non-exudative CNVM as well. So this is a patient who has optic disc infarction following stenting of the carotid artery. So we see area of optic disc edema, but a blue reflectance image shows a larger area of retinal edema along with optic disc edema. So blue reflectance definitely good for evaluating the anterior retinal findings. Multicolor imaging is sometimes helpful in a better understanding of the pathology. This patient came with a blunt trauma, has a scotoma. So one look at it, we make a diagnosis of a choroidal rupture. But when you look at the blue reflectance, green and red reflectance, we know that the area of pathology is more markedly seen in the blue reflectance imaging. If it was a pathology of the choroid, it should have been seen in the red reflectance image. So now we know it's an anterior retinal problem. So an OCTA is done, and you see that there is a rupture of the superficial and deep capillary plexus, along with an OCT showing a vertical cleavage plane at the anterior retinal surface. So this is a rare occurrence with a blunt trauma. This is an anterior retinal rupture in a blunt trauma rather than a choroidal rupture. This is an unhappy patient who came to me after a macular hole surgery done elsewhere. Vision was 6/9, but he's unhappy. Subtle changes in the retina is picked up better with multicolor imaging. You can see wedge-shaped retinal nerve fiber layer, dissociated area seen, called a DONFL. Ultra-wide field imaging with a multicolor imaging. Any imaging which shows between 100 to 200 degree of field is ultra-wide field imaging. Wide field imaging is from the posterior pole up till the equator or the vortex ample. So ultra-wide field imaging helps us in diagnosing and documenting peripheral retinal lesions and also helping us in following up cases. This is the case of peripheral retinal vasculitis, which is followed up over 3 years and did very well with the mycophenolate mofetil. Retro-mode imaging is a new kid in the block, and we are still exploring the possibilities of that. It uses a scattered infrared light to detect abnormal reflections in the choroid, and a 3-dimensional image is created of a retro-mode, and this is retro-mode imaging of a RAP patient, RAP with, RAP with CNBM. One has to be aware about artifacts in multicolor imaging, namely the central ghost spots and the Pebble Beach artifact. So it is faster, it can be done with a non-dilating pupil. Photophobic patient, you get a better image because it doesn't use light. Get a good clarity image in media opacities. Peripheral imaging is at its best with multicolor imaging. It has got better contrast, and lesions at the different level of the fundus are defined better. The demerits are, it is expensive, need a little bit of training to take the image, and pseudo color and artifacts are something which has to be looked into. Thank you very much.
Thank you, Dr. Shane. One question, how often do you ask for multicolor image in your routine practice? Or clinically, how much it is useful?
If you ask me, my practice has changed massively after this came into my practice. I will quote a small example. I didn't have, lack of time, I did not put that case to you. A patient underwent retinal detachment surgery elsewhere, came to me 20 days post-op. Retina was attached, we all know, retina was attached, send him off. He came after 3 months with a recurrent retinal detachment. So he argued with me that, doctor, at that time you saw me, retina was detached. You did not find it out. Luckily, I had a peripheral fundus imaging of him, like an ultra-wide field image. I could show him and say that, see, it was attached at the time. So I have made it a part and parcel of my practice. So what happens is, I have an imaging person who's taking pictures. When patient comes in, almost all, I make it a point to take. So it has really changed the way I manage, is what I would like to say.